And here the end plate parallel is not our target. What is important is pedicle should go within the middle of the vertebra. Because ultimately you want to go into the middle of the vertebral body. And because the end plate is not basically fractured, so there the end plate parallel you cannot do it. So this is true epi. Pedicles are very nicely seen. So now what we'll do is make it oblique on either side. So from where you will be entering? Upper and the outer. Why superior and why that? Because why not inferior? Why not medial? If we do it inferior lateral, there will be nerve root crossing. Inferior is you have seen the nerve root goes down. So that is the nerves are passing. So to keep your needle, if you are puncturing the pedicle, and it might be damaging the nerve. So that's why to keep it away, you have to superior lateral part of the pedicle.
Insert the guide needle in the superolateral quadrant of pedicle in AP view and look in lateral view.
Because I need to give the local anesthetic over the periosteum. That is one of the painful area. Fine. Pedicle is now seen very nice down. Picture.
With the blade, make a small nick to insert Jamshedi needle.
That is enough.
Adjust the direction of the needle towards pedicle. In AP view, needle tip should not cross the medial line of pedicle.
Upper part of the cortex is fractured. So I am intentionally trying to avoid that part.
Insert the needle gradually in lateral view and check position of the needle in AP view, that our needle doesn't cross medial border of pedicle till we enter into the vertebral body.
We have still not crossed the medial border. So we are very safe. So again, let.
We have crossed the medial pedicular line now after entering the vertebral body.
In the lateral view only, you can appreciate whether the cement is linking posterior.
Radiopaque PMMA bone cement is prepared by mixing methacrylate, liquid monomer, with polymer powder, resulting in exothermic polymerization. After thorough mixing, the cement is kept aside to allow polymerization and hardening.
Whether the frank blood is coming or not. If the frank blood is coming, then we should be repositioned. If frank blood is, if we are aspirating blood is always because the marrow has the bone marrow. But dye is also some people earlier in my early days I used to give the dye. Nowadays I don't give dye because dye if you are giving, what will happen? The dye is basically making your things obscured.
Cement is injected in small incremental dose under continuous fluoroscopy and look for any posterior spread of cement into the spinal canal. Slowly change the position of the needle so that cleft of the fracture gets filled with the cement.
Okay, now it's filling the cleft also. That is very important. That cleft filling was very important. I was just for that. I was thinking to reposition the needle and then go into the cleft. Because cleft fracture is basically the cause of thing. Means that cleft is continuous with the fracture side from here. That's how it is going. Normally that only happens. Picture again, continuous. But problem is it can come posteriorly because of I should not be feeling more.
In AP view, look whether cement has crossed midline.
Cement might be coming into the posterior cortex because that fracture is continuous.
Following initial cement injection, a brief pause is taken to permit partial polymerization and fluoroscopic assessment prior to further cement delivery.
Going into the disc anyhow. Yes, sir. Basically, it can make the disc less pliable. It's normally what is the function of the disc. But it doesn't cause. So that doesn't cause any major problem. Cement has gone anterior, so that cleft. So, but anteriorly we are not worried. We are worried. Anything coming in the posterior cortex also, I am very worried.
Style is reinserted into the needle, pushing approximately 1 milliliter of residual cement within the needle back into the vertebral body.
Most important part is to feel the cleft because when the cleft was filled, it was possible that it is coming directly. Everything, whatever I am pushing, everything is coming into the spinal canal. That is very important. Normally, little bit of coming into the spinal canal will not cause much problem. So that's why we should be always injecting deep by this. So even if little bit of the cement is leaked in the canal, that doesn't cause any major problem. So that is the endpoint to inject endpoint. Endpoint is the cement is going to the other side. Here, this is a cleft fracture. So filling the cleft is the endpoint.
After complete polymerization, the needle is withdrawn using a slow screwing motion under fluoroscopic view.